All suture anchor repair of an acute isolated distal biceps femoris avulsion. To begin, the patient is positioned supine on the operating table and a thorough ligamentous exam is performed. The exam should include varus and valgus stress testing at 0 and 30 degrees, a Lockman exam, external rotation, recurvatum testing, and a dial exam. A well-padded tourniquet is then placed high on the operative extremity before placing the leg in an arthroscopic leg holder. The contralateral leg is positioned in lithotomy and fitted with a pneumatic compression device. The end of the bed is lowered to allow adequate space for operative extremity manipulation. Then, the patient is prepared and draped using standard sterile techniques, and the leg is positioned using the Spider 2 limb positioner. Anatomic landmarks are then mapped out to provide visual reference points of the fibular head and Gertie's tubercle. Exposure is then obtained using a lateral hockey stick incision with the leg positioned at 90 degrees. Electrocautery and sharp dissection are used to dissect the subcutaneous tissue down to the superficial layer of the iliotibial band, then over the long and short head of the biceps femoris. Attention is then turned to the common peroneal nerve in the fibular neck. In most cases where intersubstance swelling of the nerve is observed, neurolysis should be performed to minimize the risk of foot drop postoperatively. Next, the retracted stump of the biceps femoris is identified. The fibular collateral ligament, or FCL, may serve as a valuable landmark given that the distal tendon of the biceps femoris inserts into the fibular head, closely associated with the insertion of the FCL. Once identified, the retracted stump is mobilized and tag sutures are placed to pull traction towards the biceps femoris insertion point. The muscle belly is freed of adhesion circumferentially with blunt and sharp dissection. The posterolateral aspect of the fibula is then prepared. A curette and electrocautery are used to remove tissue from the fibula and create space for placement of the suture anchors. .8mm Q-fix all suture anchors are then placed on the prepared site. Using a free needle, the suture tapes are passed through the distal biceps in a Krakow fashion. With the knee at 30 degrees of flexion, the suture tapes are fixed. Care is taken to ensure adequate tension is placed to create a stable construct. After this, the knee is ranged from 0 to 90 degrees to ensure no mobilization of the tendon is appreciated within the footprint attachment. At this point, the overlying fascia and surgical site are closed in a standard layered fashion with 2-0 and 3-0 monocryl. Immediately post-op, the patient is placed in a knee brace locked at 60 degrees. The patient should remain non-weight-bearing for 6 weeks while avoiding hip flexion coupled with knee extension. At 6 weeks, the patient may begin weaning off crutches and initiate weight-bearing as tolerated progression. Return to full sport is anticipated by 6 months.